introduce our speaker. So we have Dr. Adenique Alleyne. Dr. Adenique Alleyne is a senior house officer on the COVID-19 rescue team in Trinidad and Tobago, where she's joining us from tonight. And alongside this, Dr. Alleyne works with a charity in Trinidad and Tobago called Helping Her TT, whose goal is to end period poverty, which is very common. Her love for fitness and medicine was nurtured at St. George's University and at the NNUH England, where she volunteered her time to hold workshops to help her colleagues develop their clinical skills and assisted in coordination of the practical UK board exams, which contributed to her organisation skills. She developed a strong interest in research and surgery when presenting research at the ESPES 8th Annual Congress 2018 in Belgium, entitled Prevalence of Adhesive Bowel Obstruction Post-Laparoscopic Surgery in the Pediatric Population. Since completing her medical education, she's been serving where the need is great on the COVID-19 rescue team to help control the mortality rate. And with life taking so many unexpected turns, her mantra is manifest your best reality. I like that mantra. And you sound like a very busy woman, Dr. Adenique. So please, I'm now passing over to you. Thank you very much for joining us.
Thank you. Good night, everyone. Let me just share my screen. All right, so great night, everyone. I am so happy and grateful to the BCDD and the organizing team for allowing us the opportunity to meet tonight. And thank you to everyone who has dedicated their time and prioritized attending. So I'm Dr. Adenique Alleyne, and tonight's topic is lower urinary tract symptoms, where we will be discussing what is the lower urinary tract symptoms, benign prostatic hyperplasia, and other common causes of lower urinary tract symptoms. So let's begin by understanding what is the lower urinary tract. So here we have a visual representation of the male anatomy, and the lower urinary tract consists of the bladder and the urethra. Now, the bladder is this organ that is responsible for storing urine, and the urethra is this tube connected to the bladder, which is responsible for transporting that urine from the bladder to the environment. Now, healthcare workers use the term lower urinary tract symptoms to describe any symptom that they think is associated with the bladder or the urethra. Therefore, these symptoms can be broken down into two main categories: storage symptoms and voiding symptoms. So in the storage category, these symptoms are urgency, which is that sensation where you need to go to the bathroom immediately or you will leak urine; urinary incontinence, which as depicted here is the leakage of urine. And this can happen in any quantity, whether it be drips of urine or a flood of urine. And the last two symptoms, frequency and nocturia. Now, frequency describes the number of times that you're going to the bathroom throughout the day. For the average man, the normal tends to be around 4 to 10 times per day. And nocturia just describes waking at night to pass urine. Now, in the voiding category, all the symptoms are related to the flow of urine. Thus, those symptoms are hesitancy, which is where you go to the bathroom, you're ready to pass urine, but you have to wait a few seconds or more before you're able to pass urine; or the feeling of incomplete emptying, where you just attempted to pass urine, but however, you don't feel like you've completely emptied your bladder. Decreased stream, which is experienced as a decreased flow of urine compared to when you were younger, and this tends to happen to all men at some degree as they get older. Intermittency, which is described as a start and stop stream of urine, so it's a non-continuous flow. And dribbling, which can be experienced in all three phases of urination. So it can happen while your bladder is still filling, and this would be referred to as incontinence. Then you can also have what we call terminal dribbling, which is where you start urine with a strong stream, and coming to the end of the stream, it slows to dribble. And you can also experience this after you just passed urine. So you have that feeling where you've incompletely emptied your urine, you've already buckled up, you're ready to go, and you leak urine. So let's take, for example, the symptom nocturia, right? This will demonstrate that these symptoms can occur in multiple disorders. So for example, nocturia can be as a result of drinking too much fluid. So if you drink too much fluid, you pass more urine. A reduced bladder capacity, as with a smaller bladder capacity, you'll be more likely to overflow. A decreased body clock, as you tend to pass more urine throughout the day. So some people's body functions occur such that they function at night as if it were daytime. And this all depends on work style, lifestyle, these kind of things, right? Diabetes, where you pass sugars into your urine, and as a result, you create more urine. Also infection of the urinary tract and swollen ankles. So this demonstrates that any one of these symptoms can present in multiple disorders. So it's ever so important for you to seek medical attention so you could be accurately diagnosed and treated. Now, the most common disorder that we tend to think about when we think of lower urinary tract symptoms is benign prostatic hyperplasia. Now, the prostate is this small gland that is about the size of a walnut and is located underneath the bladder, and it surrounds the urethra, which is that tube that carries the urine out into the environment. Now, what happens as men tend to get older is that the prostate enlarges. Now, exactly why this happens is still a subject of research, but it is associated with hormonal changes. For example, the male hormone testosterone in its active form is called dihydrotestosterone. And this compound, DHT, actually stimulates the prostate to enlarge. As the prostate enlarges, it squeezes on the urethra as demonstrated in this image, and that causes an obstruction of the urinary flow, and as a result, you experience those lower urinary tract symptoms, the storage symptoms and the voiding symptoms. Now, benign prostatic hyperplasia is not a cancerous cause, and it's not really a lot of patients tend to live with their symptoms as long as they are reassured that it's not prostate cancer. However, if you are untreated and you have these symptoms for a prolonged period of time, there can be damages which are irreversible to the bladder and the kidney. For example, we understand from this disorder that the prostate enlarges and obstructs the flow of the urine. However, you don't stop making urine, you continue making urine. So as a result, this buildup in the bladder causes a buildup of pressure. It stretches the wall of the bladder and causes outpouchings that we refer to as diverticular. These outpouchings can also become infected as well and lead to lots more problems, right? Now, this backflow and this increased pressure can also go up what we call the ureters, which transports the urine from the kidney to the bladder. And this can result in irreversible widening of the ureters, referred to as hydroureter. This can also extend all the way to the kidneys and cause irreversible widening of the kidneys, referred to as hydronephrosis. So now that we understand what this disorder is and some complications associated with it, some patients also experience what we call acute urinary retention. So this is where you have severe lower abdominal pain and problems passing urine. This is a medical emergency. So if you're experiencing these symptoms where you're having problems passing urine and severe lower abdominal pain, you would need to go to your nearest hospital emergency department so you can have a catheter passed, which is a narrow, flexible tube that we pass gently into the bladder, and this allows you to empty urine, right? So now that we understand what these complications are and we understand what benign prostatic hyperplasia is, let's discuss diagnostics, right? So you're probably wondering, how does your doctor diagnose this? And there are a few tests that need to be done in order to diagnose benign prostatic hyperplasia while ruling out other more sinister causes. For example, a urine test for infection and blood tests for kidney function and prostate-specific antigen, and this just alerts the urologist that they should be investigating further. Digital rectal exam just to assess the texture of the prostate, which is very important. A urine flow test and even an ultrasound scan of the bladder, and this will help to determine if you're adequately emptying your bladder. Now, some patients tend to have severe irritative symptoms. So these are things like passing small amounts of urine, going to the bathroom a lot more often, having urgency, or even signs of infection or blood in the urine. And we will then advise something called a flexible cystoscopy. So as demonstrated on screen, this is a flexible tube, and what it has is a light and a camera at the end. It's a very slim tube that we pass gently into the bladder, and this allows us to visualize the entire internal surface of the bladder. So now that we understand diagnostics, let's discuss the treatment options. Now, there are three categories for treatment. There's conservative management, there's medical management, and there's surgical management. So conservative management is usually applicable to gentlemen with mild symptoms, and generally gentlemen with mild symptoms tend to be happy to live with their symptoms or tolerate their symptoms as long as they're reassured that it's not prostate cancer. So some of these conservative management strategies would include reducing fluid intake at night, reducing caffeine intake, avoiding constipation, stop smoking, refrain from using over-the-counter cold and sinus medications, and bladder retraining. Even with conservative management, some patients still have bothersome symptoms, and this is where we refer them for medical management. So we understand that the main problem here is the enlargement of the prostate, which narrows the urethra and blocks the flow of the urine. Therefore, to relieve this pressure, there are two ways that this can be done. One, using what we call alpha blockers, and these will relax the neck of the bladder and the prostate and thus widen the urethra and allow the urine to flow more freely. Another option would be using what we call 5-alpha reductase inhibitors, and these will then reduce the size of the prostate and as a result widen the urethra and allow the urine to flow more freely. So these are two ways that you can widen the urethra and relieve the symptoms that the patient is experiencing. Even with medical management, some patients still, even if they have severe symptoms, it won't be managed adequately. So we refer them for surgical management. Now, there are two procedures that can be done. One is called a transurethral resection of the prostate. And as demonstrated on screen, we use what we call a resectoscope. So this tool is a telescope-like instrument. It's very narrow, and it contains a wire loop inside and a camera that allows us to see exactly what we're doing. And what happens is we use this wire loop and we just remove small pieces of tissue that is causing the obstruction. So this way, when you remove those bits of tissue, you allow the urine to flow more freely. We also can do what is called a transurethral incision of the prostate. And instead of removing tissue, this is where we make a small cut in the prostate and thus widen the urethra and allow the urine to flow more freely. Now, these procedures are done around the space of 30 to 60 minutes, and they're usually done under anesthetic. So whether that be general anesthetic where you're put to sleep, or it can be a spinal anesthetic where you just numb from the waist down so you don't feel the procedure. So we've just discussed what is the lower urinary tract, some lower urinary tract symptoms, benign prostatic hyperplasia, and we've also discussed the diagnostics and some management strategies. So it must be noted that even though one of the most common disorders that we tend to think of when we think of lower urinary tract symptoms is benign prostatic hyperplasia, there are other causes of lower urinary tract symptoms, and these are overactive bladder, diabetes mellitus, urinary infections, bladder stones, prostate cancer, bladder cancer, and neurological conditions or nervous conditions such as multiple sclerosis. So it's ever so important that if you're experiencing these, what we call lower urinary tract symptoms, that you definitely seek medical attention so that you can be adequately diagnosed and treated. Thank you everyone for listening, and I'll definitely turn you back over to the host.
Thank you so much, Dr. Alleyne. That was really informative. I think it's such an interesting topic because I know myself, especially before I became a doctor, and I think generally we think about urinary infections in relation to women. So to hear about them in relation to men I found that really helpful. So I hope everyone else did too. So thank you again. Really informative, interesting talk. And can I just ask quickly, obviously we're going to do questions at the end, but I was just wondering, Dr. Alleyne, what would you say if you could choose one take-home message for men with regards to urinary symptoms? What would that be?
The one takeaway would be that you want to understand your body and understand what the difference is, because even though some patients would have what we say is frequency, for you, your normal might be 6 times a day, 7 times a day, and you will then notice that now you're going 10 times a day, and that's a problem for you, or you're going a lot more frequently. So you need to understand your body, and only then will you be able to understand what the changes are. And then definitely, I would say always seek medical attention, because simply coming to a presentation like this, you would think that, okay, I'm having some of these symptoms. The most common thing is benign prostatic hyperplasia. I'm self-diagnosing and I'm not going to go to seek medical attention. But there are so many other causes. So you need to, go to your medics and definitely get investigated, because a lot of things would need to be done. And yeah, that's my takeaway from today.
That's great. Thank you so much. And we will see you again at the end for some questions.
For sure.
Thank you. Okay, so for our second speaker, we have Dr. Itam. And we're very lucky to have her, just as we're lucky to have Dr. Adenique. So, sorry, got a frog in my throat. I'm PCR negative, by the way, so don't worry. So Miss Sarah Itam is a qualified consultant urological with a U surgeon with a specialist interest in male and female reconstructive urology. She's worked in several specialist UK centres, including Guy's and St Thomas's and University College London Hospital. Sarah gained a distinction in her Masters in Surgical Education from Imperial College, one of the few courses of its kind in the country. She's combined this with her enthusiasm for public engagement and participated in various events, including prostate cancer awareness for Orchid Cancer Charity, NHS at 70 for the Wellcome Trust, and was featured on David Olusoga's BBC One documentary, RNHS, A Hidden History. That was really good. I don't know if some of you saw it. I watched that and it was wonderful. So Miss Itam is an engaging and motivational speaker who is dedicated to improving public knowledge in disease awareness and prevention. So, Miss Itam, whenever you're ready, the stage is yours.
Thank you. Good evening, everyone. Thank you for having me and thank you for inviting me. And it was a great talk we had from Dr. Alleyne, and it really sets the stage for what I'm going to present next. So my remit is to present on prostate cancer, and let me share my screen with you. Can you guys see that okay?
Yes, that's great.
Perfect. So today we're going to, in terms of this prostate cancer, we're going to, the aims of this part of the presentation, and in the short space of time, we're going to cover the location and function of the prostate, which we've touched on already. We'll understand the significance of the PSA, or the prostate-specific antigen. We'll understand the controversy surrounding prostate cancer screening, and we'll know how prostate cancer is diagnosed and managed, review the treatment options available, and discuss potentially the relevance of a healthy lifestyle. So as we've discussed already, where is the prostate? So this is the bladder in my picture, and you can see the urethra here, the water pipe, and surrounding the urethra is the prostate, which is about walnut shaped, and it wraps around the urethra. So as we've discussed, urine is stored in the bladder and exits through the tube here, the urethra. Talking specifically about the prostate and what it does, the prostate produces prostatic fluid, and the prostatic fluid forms semen, which enriches and nourishes the sperm. In terms of incidence, we know now that prostate cancer is the most common cancer in men. 1 in 8 men will be diagnosed with prostate cancer in their lifetime, but this is higher in Black men, crucially. And actually, you can find data which states that every 45 minutes, 1 man will die from prostate cancer. So it is a relevant disease that we're talking about today. We don't know what exactly causes prostate cancer, but there are some things that increase your risk of potentially developing it. And that's what we call risk factors. So these include age, family history, and race. Let me talk about those in turn. So if you look on this graph here, you can see that as you get older, your risk of prostate cancer increases. And there's nothing you can do about getting older. If we also look at family history, if you have a first-degree relative, so a father or your brother has been diagnosed with prostate cancer, and especially if it's at a younger age, then that more than doubles your risk of developing prostate cancer. Interestingly, we know that there's certain genes which are responsible for breast cancer in some cases, which also, if your mother or sister has been diagnosed with that condition, can increase your own risk of having prostate cancer. But just because you have a family history doesn't mean you will develop prostate cancer. And let's talk about race because of the context in which this session today is held. Remember I said that 1 in 8 men, non-Black men, will get prostate cancer at some point in their lives. But look at the statistic here. 1 in 4 Black men will get prostate cancer at some point in their lives. We don't know why this is. Maybe it's because of genetics, and we're looking into it in terms of research, but that's one thing to note. So let me do some myth busting. Too much sex can cause prostate cancer. I'm afraid to say that simply isn't true. So that's a myth that we can lay to bed. Another myth, as we've spoken about, prostate cancer is an old man's disease. You remember from the slide I showed previously that yes, it does increase as you get older, but prostate cancer has been detected in younger men as well. So it's not an old man's disease, and we shouldn't just reserve it for old men. So now let's talk about the PSA prostate-specific antigen that's been mentioned. So remember I spoke about the prostate producing this prostatic fluid that helps carry and nourish the sperm. Well, PSA, or prostate-specific antigen, is a protein that's found within that prostatic fluid. It allows the semen to be nice and liquidy so the sperm can swim around freely. PSA is mostly found in the semen and prostate, and it's a protein. But small quantities can seep into the blood. So when you hear people say that they've had their PSA done, what they're referring to is that they've had a blood test. The PSA level in the blood, if higher than expected, can alert us to think we need to start investigating. Crucially though, just because you've got a raised PSA, it doesn't mean you have prostate cancer. There are other conditions. So we've spoken about an enlarged prostate. We've also spoken about acute retention, where you need that flexible tube or the catheter passed into your bladder. You can have inflammation of the prostate. You can have urinary tract infections, again mentioned in the previous talk. So there are other causes for raised PSA. So what are the symptoms of prostate cancer? You're all probably wondering. And I've left this slide blank on purpose. That's because one of the important things we need to stress is that prostate cancer in some men can present with no symptoms. That's what we call asymptomatic. So not every man who will be diagnosed with prostate cancer may actually have any symptoms at all. But then we spoke about lower urinary tract symptoms, and we went into the voiding symptoms and the storage symptoms, which I won't reiterate. But just to mention that these symptoms, some men can present with these, which actually they go on to be diagnosed with prostate cancer. But as we've said, they're not specific to prostate cancer. Some men who are diagnosed with advanced prostate cancer may develop bony pain, And that's because when the prostate cancer escapes beyond the prostate, one of the places it can travel to are the bones. And so they might present with bony pain. So that's our normal prostate, that's our enlarged prostate, a completely different condition to prostate cancer. So benign prostatic enlargement is a different condition to prostate cancer. And this condition is non-cancerous. So then let's recap. Having lower urinary tract symptoms does not mean that you have prostate cancer. I'll let that sit for a bit. Having lower urinary tract symptoms does not mean that you have prostate cancer. And that leads me to my myth 3. I don't have any symptoms, so I can't have prostate cancer. I hope I've busted that one for you. Just because you don't have any symptoms, it doesn't mean you can't have prostate cancer. I'll let that sit for a bit. So then you might be asking me, but don't we screen for prostate cancer in the UK? After all, several men are affected. We know it's the commonest cancer in men, and people can die from prostate cancer. Well, in a word, no, there is no national screening programme for prostate cancer. And that's because in order to have a screening test, there are certain factors that need to be satisfied, and prostate cancer doesn't satisfy all those conditions. For example, the tests of screening should be easy to perform, interpret, acceptable, it should be accurate. We need to know the natural history of the condition, and the treatment, if started early, should be effective. Let me just mention something. Sometimes men are diagnosed with prostate cancer, and actually it's the sort of cancer which is not going to affect their quality of life or actually doesn't need treating. And the fact that there can be such a range in prostate cancer prostate cancer severities means we don't quite understand the natural history in comparison to something like breast cancer, where we know that if you've diagnosed with a cancer, breast cancer, the treatment is to remove it. The same is not as equivalent in prostate cancer. And generally, the PSA, as we've spoken about, is not reliable enough on its own to diagnose prostate cancer. So that leads me on to my myth number 4. I will receive a letter from my GP to have my PSA done. Unlikely, because you may do, but actually it's not incumbent on your GP to ask for your request for your PSA to be done, because as I said, there is no national screening programme in many countries, including our country. So the likelihood is that you will say to your GP, "Doctor, can I have my PSA done, or can I be screened for prostate cancer?" And that's what will generally happen. Remember, we do know that early diagnosis may save lives. So you go to your GP, the GP will take your history, do a digital rectal exam, and send you, so that's a digital rectal exam, and we're feeling for the texture of the prostate as mentioned, and looking if there are any abnormal areas that we think could need further investigation. Send you off for your PSA blood test, and actually, if those things point to something that we need to investigate further, so you've got a normal digital rectal examination, or your PSA is higher than expected, then you may see a urologist or a urological surgeon. And there the urologist will probably repeat the history, the examination, and repeat the PSA just to check that it actually is raised. And depending on the results of the examination, the PSA, then you will be likely go on for an MRI. That's a magnetic resonance imaging scan. And what that basically does is take detailed images of the prostate, because what we're looking for here are any abnormal areas. And if there are any abnormal areas, the MRI nowadays is so good that actually we can target those biopsies. And a biopsy is a sample of tissue, taking the sample of the prostate and actually looking under the microscope to see if there are any abnormal cells. So I've said a lot so far, and one of the things I am is an ambassador for Orchid Cancer Charity, which does some fantastic work in increasing the awareness of prostate cancer among men and their families, and they help support men and their families who are diagnosed with prostate cancer with, helping them along the way. So ORCID has some fantastic resources on their website, which I will point you to after this presentation. But let me show you animation which they've produced, which I think really helps give a synopsis of what we've just mentioned. So let me stop sharing my slide and I'll share the animation for you.
If prostate cancer is suspected, a special type of MRI scan can be used to visualize the prostate gland and may help identify potentially cancerous areas. Samples or biopsies from these potentially cancerous areas can then be taken, and taking biopsies in this way can in turn improve the accuracy of diagnosing prostate cancer. The biopsies which are obtained are analysed in the laboratory to give a grade of prostate cancer, and this is called the Gleason score. Today, the Gleason score is measured on a scale from 3 to 5. The cells in Gleason grade 3 are very similar to normal healthy cells. The cells in grade 5 are very abnormal looking. The most common type of cancer cells are allocated a score between 3 and 5. This is then repeated for the second most common type of cancer cells, giving 2 scores which are then added together to give a final score out of 10. To make the potential risk of the prostate cancer progressing easier to understand, the scores are placed in groups according to their potential risk, with 1 being very low risk and 5 being high risk. Men in group 1 are typically given the option of active surveillance, although this can also be an option for some men in group 2.
Recording in progress.
Good. And so I hope that helped clarify for you actually what happens and the biopsy process. And sometimes men might be required to have a bone scan. And remember I said that the likeliest place for prostate cancer to spread to are the bones. And so this bone scan helps us detect if the prostate cancer has escaped to the bones. So now you might have been diagnosed with prostate cancer because the tissue from the prostate or the histology has demonstrated these abnormal cells. And so what will happen in the hospital setting is that your case will be discussed in a multidisciplinary team meeting, that's the MDT. And what happens is there's specialists there who have looked at your biopsy, have looked at the MRI scan, which we spoke about, and put their heads together and work out what's the best treatment option for you. Now, if you're diagnosed with prostate cancer, hopefully it's at the early stage, and the idea is for curative intent, and some of the options include active surveillance, a radical prostatectomy, radical radiotherapy and hormones. And there are other treatments, but those tend to be in the context of clinical trials. So let me just give you an overview of what they may entail. So active surveillance, what the aim is here is to avoid overtreatment. is frequently offered to men who have low-grade and low-volume prostate cancer. We know that treatment to cure prostate cancer can have side effects, and it may turn out that the prostate cancer that you had was the one that was not really going to bother you at all. It was unlikely to progress, and it wasn't going to pose a threat to your life expectancy. So that active surveillance allows us to keep an eye on the prostate cancer, and if there is any sign of progression, to intervene in that window of opportunity so you could still be offered curative options. And then you have radical prostatectomy, and nowadays in the UK, many people have this operation with a robot-assisted prostatectomy. That's removing of the prostate. We know the cancer cells are in the prostate, and so we take the prostate away. But it's not without its risks, and some of the complications include erectile dysfunction, urinary incontinence, and narrowing of the water pipe or the urethra. Again, we look at radical radiotherapy also in the context of curative intent, and that tends to be given with hormones. And that's where the radiation is applied to the prostate to try and kill the cancerous cells. But again, there are complications associated with radical radiotherapy. And also, we know that the prostate cancer thrives in the context of testosterone. So what these hormones do is to deprive the prostate cancer cells of testosterone to try and help with your prostate cancer management. But notice, testosterone is very important for other things in our body, includes heart health in men, heart health, bone health, your libido, and therefore even these curative intents are not without their complications, which is why if active surveillance is an option for you, that is something to consider. The good news is, though, is that even with all these complications, we have got treatment strategies that can help treat, that can help manage them. So all is not lost, even if these complications were to affect you, should you need to go onto these treatments. Now, if you're diagnosed with prostate cancer that actually is more advanced, then sometimes men may be put on watchful waiting. And this is not the same as active surveillance, so I thought it's important to clarify. It tends to be an option for older men or men who have multiple medical problems or comorbidities, and they don't obviously have any symptoms, and the prostate cancer is not really affecting them too much. That's because offering them the treatment, which we spoke about, would have more deleterious effects than actually just watching to see how the prostate progresses, and only intervening should they have symptoms. It's about the quality of life, the future quality of life, and we do know that some of our treatments can actually have significant side effects. Other cases, if you are diagnosed with advanced prostate cancer, can include palliative radiotherapy if you've got bony pain, and that's trying to ease the pain that you experience in the bones. Also, we spoke about the hormonal therapy and chemotherapy, and these are all in the context of trying to control the disease, but not actually curing it in itself. So as we finally go to the last few points of my presentation, you may be asking me, but what can I do to help myself? So at the moment, we're trying to look at the ways of preventing prostate cancer, and the verdict is still out. No one really knows how you can prevent prostate cancer. But hey, we know that a healthy lifestyle is important in many other conditions. So why not prostate cancer? We do know that being overweight may increase your risk of being diagnosed with advanced prostate cancer and prostate cancer that's aggressive. So actually we do encourage exercise. And also, even if you are diagnosed with prostate cancer, exercise is very important still. You may have heard that certain foods may lower your risk, include pulses, beans, peas, and there's a whole list of them. The truth is there isn't really strong evidence for us to actually mandate this. You may have also heard that eating red and processed meat increases your risk of other types of cancers. And whilst we don't know whether it increases your risk of prostate cancer, we do know that it's not causing any harm. So advise patients to have a colourful plate, more fruit and veg, and less reliance on the red meat, and reduce your consumption of fat, because we do know in other diseases this actually helps. So in conclusion, prostate cancer is the commonest cancer in men. It may present with no symptoms. We don't routinely screen for prostate cancer in the UK, so you will never get that letter currently. We do know that early diagnosis may save lives. And importantly, in the context of this session, we do know that Black men are at increased risk of being diagnosed with prostate cancer. Thank you for listening.
Wow, thank you very much, Miss Itam. And I must tell you that you're stirring up some passion in these people, because the questions were just flooding in during your talk. So I hope you're ready for that, but we'll save them till our final speaker. But thank you very much for that. That was really informative. And like I said, people have obviously found it really, really interesting. So thanks again. Okay. So last but not least, we have another consultant. We have Miss Ayo Kalejaiye, and who is a urology consultant at University Birmingham NHS Trust. Miss Kalejaiye has been a consultant for about 4 years, having trained predominantly in Southwest England before completing a fellowship at University College London. She specialises in penile cancer and benign andrology, which is the bulk of her work. Her interests outside work are travel and wellness. So I'm now going to hand over to our final speaker for her to give us some more knowledge. I'm sure we've got a little bit more space left after those two talks.
Good evening, everybody. The previous two speakers are absolutely fantastic. So I've got my work cut out really to compete with them. I hope you can see my slide. So I'm going to be talking about erectile problems. That's about half of my work is on problems with sexual function. So I actually love talking about it a lot. The other side is penile cancer, which can be a little bit more depressing. So we often think about sex as something that is a bit taboo. We shouldn't really be talking about it with our doctors, but good erections and good sex is a real marker of good health, of good health. So you should always be hoping and aiming to have a good erection. And that's an erection that is sufficient to have penetrative sex, if that's what you want, or any sort of sex that you want, whatever floats your boat. So exactly what is erectile dysfunction? The pictures really say it all. Erectile dysfunction is where the erections are just not hard enough for you to either penetrate or do whatever it is you want to. And it's often associated with poor relationships. Your partner may feel that you're not as attracted to them as you were previously. They may feel that perhaps there's somebody else that you're seeing outside of your main relationship, which may be true, but you may not want your main partner to know that. So that's what erectile dysfunction is. How common is it? It's very common. There's a very old study, it's over 20 years old now, that was initially done in the States, in Boston. Over thousands of men were included. And one of the parts of the survey was really asking them about erectile problems. And they found in the end that about 51%, so just over half of the men who participated had problems with their erections. You can also see that it increases as you get older, and the severity of it increases as you get older as well. And that data has been replicated in multiple studies ever since then. And we know that about 1 in 5 men over 40 have a problem with their erections. So it's something that you shouldn't be embarrassed about. Lots of guys have this problem. It doesn't mean that you should accept it though, and we'll talk about that later. So what are the risk factors that may point to you getting erectile problems? And it's all the things we know. So smoking affects your erections. If you drink alcohol excessively, it will affect your erections. Some of the medication that your doctor may put you on may affect your erections. Diabetes, heart disease, and some surgeries, including treatments for prostate cancer, can all affect your erections in an adverse way. Stress is another big erectile killer. Now, what I tend to tell my chaps when they come into clinic and they're in highly stressed jobs, or they're in a very stressful relationship, or they've got stressful environment at home, is that if we lived in the time of the dinosaurs, you do not want to have an erection when you're running away from a dinosaur. It just wouldn't be something that you could do. So you have to think that all the hormones and all the chemicals in the body that go with high stress, so adrenaline, high cortisol, all go with high stress, will all adversely affect your erection. So when you want to have a good erection, you need to be stress-free. So you've got to get rid of those stressful factors in your life, whatever they may be. It's super important that you do that. The top 3 causes of erectile problems I see are patients with vascular disease, and that tends to be the patients who may have high blood pressure, they may have had strokes, they may have problems with the heart, they may have had a heart attack before, they may have angina currently, and the biggest one is probably diabetes, which we're seeing increasingly, not only in the general population, but particularly in the Afro-Caribbean population, and that goes hand in hand with obesity, I'm afraid, and obesity affects your erections. Now, we know that Miss Itam spoken about prostate cancer. Prostate cancer treatment does cause erectile problems, I'm afraid, and we'll talk about that a little bit later. But erectile problems can be an early warning that you have diabetes, that you have problems with your heart. So it's not something that you can just leave and ignore and say, well, you know, I just won't have sex for the rest of my life. There's actually a very old study now that men who have regular sexual intercourse live longer. It is part of good health in a man. They should have good erections. So erectile dysfunction and heart disease. We know that men who have erectile dysfunction will have heart disease, and that means they'll get angina, or they'll have a major cardiac event, such as a heart attack or a stroke, within 3 to 5 years of developing erectile dysfunction. And that's been replicated in multiple studies. And so when I see a young chap who's got no stresses and no obvious risk factors for having erectile difficulties, it sets alarm bells in my head that he probably needs to get his heart checked out. And if he walks in, he's young, he's smoking, maybe drinking a little bit more than he should be, and he's a little bit overweight, those are all alarm bells that a heart attack is imminent. It's gonna happen in the next couple of years. The erectile problem is the first warning. And the reason that is because of the blood vessels. So we all know that when you get a heart attack, you get clots in the major arteries supplying the heart, and then that blood vessel will eventually block off and you get the heart attack. A bit of the heart muscle dies. Now the same thing happens in the arteries of the penis. Now those arteries are much smaller, and so they get blocked much earlier than the blood vessels in your legs or in your heart, or the blood vessels going up to your brain causing a stroke. So it's not a symptom that we can just ignore. What can you do to reduce your risk factors? I've sort of mentioned them already. So if you're overweight, now's a good time to start exercising. You know, start watching your diet, look at what you're eating. We all know roughly what we should and shouldn't be eating. We just often don't really listen. You need to stop smoking. That's another one. You've got to get really good control of your diabetes. Please take your blood pressure medication. All of those will help with your erections and will mean that when we get onto treatment, you're much more likely to respond. But key before all of that is please talk to your doctor, whether that's your GP or you ask to see a urologist. Now, a urologist who specializes in erectile and penis problems is called an andrologist. That's what I do. So you can ask to speak to your local andrologist, where it's slightly what's the word? There aren't a huge number of us in the country, but every major city in the country will have an andrologist in their centre. So you can just be referred to your nearest big city's urology team, and they'll have an andrologist almost definitely there. But you do have to ask the question. Unfortunately, a lot of doctors do not like talking about sex. They're not like me. I love talking about sex. I think it's really healthy. But, you know, we live in a society where it's a little bit taboo still. And if you feel that you can't approach your GP, just ask to be referred. It's not a big deal. Now, just reiterating again, look at your diet, exercise, lose weight, stop smoking, reduce your stress, and then recreational drugs, cannabis, heroin, cocaine, excess alcohol, they're all really bad for your erections, I'm afraid. You've got to reduce and actually ideally stop all of them. The other things you can discuss with your GP and your urologist is have a look at your medication. You know, a lot of the medication that you may be on will actually affect your erection. So for waterworks symptoms, we'll often as urologists put you on tamsulosin and finasteride. They adversely affect your erections, and there may be an alternative to that. A lot of antidepressants will adversely affect your erections, blood pressure medications, some of them will adversely affect your erections, but there are usually alternatives, and you should be able to have that discussion either with your GP or your urologist or your cardiologist, in fact. The other one is nitrates. And again, most cardiologists would say that you no longer need to be on nitrates. They're quite an old family of drugs for heart disease. There are newer drugs on the market that you can usually be swapped onto. Now, the last thing is to have your testosterone status checked. If you've got a low testosterone or low normal, your erections will not be very good, or they may not be very good. And you may need to go on testosterone replacement therapy. But you need to have your testosterone checked first thing in the mornings, anytime up to about 11 o'clock, because not most men, every man's testosterone peaks in the morning and then drops over the course of the day. That's normal. So you don't want to check it at the end of the day when it's low, naturally, because then you may falsely think that it's always low. So that's why you check it in the morning. Now, erectile dysfunction and prostate cancer. If you have prostate cancer, do not be scared about having treatment, but pick the treatment that fits your quality of life the best. Don't worry about erectile problems. We can sort that out afterwards, but you must go in with your eyes open. Whatever treatment modality you pick, you will have, almost certainly, you will have a degree of erectile problem. It doesn't matter if you have surgery or radiotherapy. It doesn't matter if you have nerve sparing or non-nerve sparing. The reality is that your erections will be adversely affected, but you should have the right treatment for you. We can sort out your erection problems afterwards. Now, what should you do before your prostate cancer treatment? Now, what I normally tell patients is go to bed early, the night before you're going to start your treatment. Take your partner to bed with you. Go up early, have lots of sex, lots and lots of sex. Wake up early the next morning, have lots of sex again, because things won't be the same. So you might as well enjoy it while you've got it there, because it may not be like that again. Certainly not as spontaneous and not as without aid to help you in most circumstances. I'm just going to talk about the treatment options very quickly. I'm hopefully going to show you a few things. So the first one is the tablets, the most famous tablet being Viagra. It's now, you can now buy that at Boots. You don't need a prescription for it anymore. It's relatively cheap, I believe. And what it does is it increases blood flow to your penis. But you do need, there are a few things you need to be aware of. So you need to be sexually stimulated for it to work. That means foreplay. You need to take, I normally say you need to take on an empty stomach. That's not strictly true, but it's the easiest way to describe what you need to do. Ideally, you shouldn't have it with fatty foods, but it's easier to just say have it on an empty stomach. You need to have it about 30 minutes to an hour before you anticipate having sexual intercourse. The efficacy is about 66%, a little bit higher in some studies and a little bit lower in some studies. It's more difficult to treat diabetic men. They're more likely to fail, but I would still always try. It doesn't mean that they all fail. Excellent treatment. It does have side effects, as you can imagine. The most common one are headaches and facial flushing, and that can be quite upsetting for some patients, and so much so that they won't be able to continue it. Now, there are other tablets in that family of drugs. They all work in the same way, but the side effect profile may be slightly different in you versus somebody else. So it's often worth trying it. The others you can't buy over the counter yet. My favorite one would probably be one called tadalafil or Cialis, simply because it stays in the body for a much longer period of time than Viagra. So it means that over the course of a weekend, you can take one tablet and have lots of sex. So it gives you more flexibility and spontaneity than Viagra would do. Viagra is much shorter half-life in the body. The vacuum device is an excellent treatment option as well. I really like it in my chaps who have had prostate cancer therapy, mainly because they can start it as soon as the catheter comes out. They can start it pretty early. It's something that ideally I'd like them to start practicing with before they have their surgery or before they start any treatment. And it involves a ring which goes at the base of the penis. Then you have a tube that goes over the top, as you can see in the picture, and that creates a vacuum. You press the button that creates the vacuum, and that will pull blood into, or cause constriction of the blood within the penis and make the penis hard. Works very well. The reason I like it is after prostate cancer surgery, we're finding a lot of men are developing a curvature in their penis for a variety of reasons. It helps to just straighten that curve out as well. The downside is it's a bit cumbersome. Some chaps don't like to have the whole rigmarole of putting this on. They find that the penis is quite cold, which is unpleasant. And as soon as they take the ring off, the erection disappears. And that is something that's not always ideal. There's just some of the other side effects. So I'm just going to show you now this. So I'm going to see if I can, I'm hoping you can see this. So this is how they're called urethral suppositories. So if you think that's the penis, if you think that's the water pipe where you pee out of, and so you'll have something like this. This isn't actually Muse, which is the most famous one. This is a newer one called Vitaros, and Vitaros is a cream treatment. So you'll empty your bladder, then you'll pass this into the water pipe. You squeeze that, the cream comes out. Some of it will spill onto the head of the penis. You just massage it in, and it will work within about 5 to 10 minutes. So it works pretty quickly. The downside is that some men will complain of burning in the water pipe. That's uncomfortable. It's probably one that doesn't work as well as some of the other treatments I'm going to talk to you about later. And the urethral pain tends to be what stops most men using it long term. But it's another good treatment option. The injection, most men, the injection is probably my favorite treatment short of surgery. I'm going to try and show you. Now, the efficacy is extremely high, but most men are pretty scared about the thought of sticking a needle in their penis, not surprisingly. But this is the needle. I'm not sure if you can see it. I'm going to try and put something on the back. Can you see that? Probably not. Let's see if I can. There we go. So it's a pretty thin needle. if I can show you, if you can believe me. And what you would have to do is it would go into the side of the penis. If you think that's the penis, it go into the side of the penis. You'd inject it yourself, and then you depress the plunger, and then that comes out. It will give you an erection within about 10 to 15 minutes. You can increase the dose up to about 40 micrograms. You normally would use one within a 24-hour period, and it usually the erection will last for about an hour. Very good treatment. Most men will complain that long term they get pain with it, and you can start to get scarring within the body of the penis. You can get a condition called priapism, which is a prolonged erection that's painful, won't go down. It's a medical emergency. The risk of that is about 1%. You have to go into hospital, and you've got to get that erection down immediately, as quickly as possible, really. But a very good treatment option. Now, the last option, I'll just go, is something called a penile prosthesis, which is probably my favorite operation to perform. And what it involves, there are two types of penile implants. So this is called a malleable prosthesis. So you've got two chambers in your penis, which are called the corpora. And one of these goes into each of the corpora. Now, this is called a malleable prosthesis. So it's an operation that usually lasts about an hour in my hands, goes in, you go home after about 24 hours in hospital. And when you want to have an erection, you bend it into a straight position. When you don't want to have an erection, you bend it into a downward position. So it's like that. The satisfaction rate is about 80% consistently in studies. It will probably last you the entirety of your life. The downside is it doesn't look like a natural erection. And you've got to be a little bit sensitive to people, and kids in particular, being around if you've got tight clothing on, because it always looks like you've got a partial erection, which some people may obviously get the wrong impression of. But the Rolls Royce of implants is something called an inflatable penile prosthesis, which is this device. So again, you've got the two cylinders, like so. They go in the penis. Then you've got the pump, which goes into the scrotum. And then you've got this called a reservoir, which is a bag of fluids that goes into your tummy. So when you want to have an erection, this is all internal, by the way, you would inflate that, you press on that in your scrotum, and the fluid, which is filled in here, goes from here, the reservoir, into the cylinders to make the penis hard. So I'm just going to pump that up, and it gets super hard, pretty hard now. And then you have sex, hopefully. Once you're done, you press this button at the top of the pump, just there, and that will release the fluid and send it all back into the reservoir. So I've got a little dummy that shows what it would look like if you had an implant inside. So just bear with me while I get it set up. Oh, here we go. So can you see that okay? So, yeah. Hold on. There we go, that's better. So this has got an implant already in it. So I'm just going to press that. You can see it's starting to go up. If I show it to you from the side, you can sort of maybe appreciate it a little bit better. And it will, the satisfaction rate for an inflatable is usually about 90% consistently in most studies. Now, like any device that's foreign to the body, there is a risk of infection. So you can see it's pretty up now. And then to get it down, I will just press the button just there, and it will start to go down. Normally give it a bit of a squeeze to deflate it more. Get it all the way down. So that works very well. And most of my patients who have that are extremely happy. It allows them to have sex again, gives you back your spontaneity. The operation is usually anywhere from 2 to 3 hours. You may have 1 or 2 incisions, depending on the surgeon. The risks are infection, which in most instances would mean that the implant's got to come out. But usually you can put another one in once the infection settles. The infection risk is about 2 to 5%, depending on the surgeon again. It's higher in diabetics, probably about double the rate. It will probably last about 8 to 10 years. If it's still working in 8 to 10 years, we're very happy, go ahead. If it's not working as well, then we call that a mechanical failure. We take that out, put a new one in. So those are the options for dysfunction. So these are just a few resources for if you have further questions outside of this this evening. These are excellent companies. The EAU is the European Association of Urologists, and these 2 companies are the penile implant companies. They've got websites where they go through erectile dysfunction for patients leading up to penile implants. I will thank you for listening. I hope I answered most of your questions. That's me done.
Thank you so much, Miss Kalejaiye. That was just incredible. And thank you so much for talking about the things that, as you said yourself, there's even a lot of doctors who are afraid to talk about sex, afraid to talk about erectile dysfunction. But it is so important, and I imagine it must have a massive psychological impact on many, many men and women who are, you know, in relationships with those men. So yeah, I can't thank you enough for actually giving us all that knowledge and talking about this topic. Thank you. So all 3 speakers, thank you so much. You've all been brilliant. And I can see we've got a lot of questions coming through. So if it's okay with you, we will start our question and answer session.